Guys, now we're going to go over ACLS, and I'm going to try and make this as simple as possible for you guys. ACLS is just the fact that you could interpret an EKG and that you could give meds. That's really what separates it from BLS, and that you're delivering the joules instead of the AD just figuring it out for you. Now, this is currently 2024. I wrote there in the corner. If anything changes, because the guidelines do change over the years, make sure you're up to date on that. So there's only two rhythms you could be in ACLS, okay? When they're going to show you the monitor, when they're testing you or in real life, it's either going to be the dead rhythm or the PEA/asystole. So the dead rhythms are VFib and pulseless VTAC. Pulse because they do not have a pulse, okay? So that means somebody could technically be in VTAC and they're alive, and you're not going to do all this, right? This is only if they do not have a pulse or if they're in VFib, which is basically a dead rhythm, okay? And it kind of looks like this. Now, if you recognize those on the monitor, right away you're going to want to shock them. There's biphasic and monophasic. Monophasic is more outdated. It's 360 joules. If it's a biphasic, it's probably going to be anywhere from 120 to 200 joules, but you have to ask your specific hospital or check your specific manufacturer because everyone's a little different. But the higher the better usually, because the patient's already dead, okay? So you're not hurting them by giving them more. Now, once you deliver the shock, you're going to ask the nurse or somebody to get IV or IO access because you need to start giving meds. First line med we always give is epi. Okay, epi, how much? You're going to give 1 mg. So epi, 1 of epi, easy dose to remember. And the dose is every 3 to 5 minutes. Easy for me to just remember right in the middle, every 4 minutes. Just a nice, easy number. While they're establishing that access, somebody's starting CPR. Remember, CPR always follows the shock. You cannot wait and just do nothing. Those precious time wasted without perfusion to the brain. So continue the CPR while the person's, getting in that IV access. It takes time, and then giving the epi. Now, after 2 minutes of CPR, go back. Shock them, right? Again, they check the pulse, no pulse, you shock. This is assuming they're still in one of these two rhythms. Now, the next dose is not going to be epi. We're going to give either amiodarone or lidocaine. Most people prefer amiodarone nowadays. Some old school doctors might prefer lidocaine, but you guys have to remember the doses. This is the first dose. First dose is more than going to be the second dose. First dose is 300 milligrams bolus of amio, or lidocaine, it's 1 to 1.5 mg per kg. Okay, this is the weight-based one. This is just straight hot 300. Now, again, while you're giving the meds, someone's still doing CPR. Very important. Okay, next, after 2 minutes of CPR, shock again. Next med, you go back and forth. You alternate. It's going to be epi 1, again, continue CPR. 2 minutes later, shock. After this, it's amio. Second dose is half of the first dose, so 150 mg. Or lidocaine 0.5 to 0.75 mg per kg, okay? It's whatever you're using. Now, you're going to just keep on getting the cycle till, either the rhythm changes and you have to go into some other algorithm, or hopefully they have ROSC, which is return of spontaneous circulation. So that means you got a pulse back and you got a blood pressure. Now, they're still not okay, right? There's any second they could go back into this rhythm. So you need to set up a drip, especially while you're transferring them to whatever floor they're going to. So you're going to either give an amio drip, IV drip. It's the dose is 360 mg in 6 hours. Easy, 360 per 6, or that's the same thing as saying 1 mg per minute. Or you could give a lidocaine drip of 2 to 4 mg per minute. Okay, easy, simple. That is the dead rhythms. Now move to the other side, even shorter. If they are in PEA, which is a condition where it looks like beautiful sinus rhythm, but when you check them, they have no pulse, so they're technically dead, even if their monitor is showing something. Or asystole, which is just flatline. Any of these, you are not allowed to do a shock. Shock, by the way, is also known as defibrillation or unsynchronized cardioversion. Not going to happen. No shock for these. You could only use your hands, do CPR, and give meds. Okay, so you're literally just going to give CPR. Make sure, I forgot to mention here, airway is very important, right? Airway, which is part of BLS, right? Get the oxygen on them, give them a mask, get a bag valve mask, make sure there's good seal, and if it's going on for a while, you're probably going to want to intubate already. Now, but until you don't have an advanced airway, it's going to be, the CPR is 30 compressions, 2 breaths, right? Once you get that advanced airway in, and even better if you could establish capnography, then it's going to be 10 breaths per minute, or 1 breath every 5 to 6 seconds. Very important to remember. And when this happens, you're not stopping CPR to do the two breaths, because it's not 2 breaths anymore. Now it's just 1 every 5 to 6 seconds, even while CPR is happening. Just important to mention that. And the drug you're giving, our drug of choice, epi 1 mg. And you just go over and over in this thing. Now, I'm bringing the H's and T's here. H and T's, you guys have to know this. H's and T's is what's going to help you get them hopefully out of one of these situations if they have one of the reversible causes. All these what we're going to talk about are reversible causes of these dysrhythmias. So let's start with the H's. So the H's, these are again are reasons why somebody might have been found unresponsive or in one of these bad rhythms. Hypoxia, lack of oxygen, okay? Now, why they're having lack of oxygen, we'll have the cardiologist or the pulmonologist or whoever figure that out later. We just know they're not getting enough oxygen, and that's why they went into this rhythm. So how do we fix that? Well, we were already doing it when we established the airway in basic BLS, right? So you're fixing that, right, while giving this. Just make sure that they're actually getting the breaths correctly, make sure there's chest rise, make sure the tube is in place. Next is hypoglycemia. Maybe they were a diabetic and they didn't know, right? Or maybe they took too much insulin. So hypoglycemia, how are you going to fix that? Treatment, D50, dextrose infusion, okay? Easy way to check for this is to get a finger stick, right? Just prick their finger, check their glucose levels. Next is hypovolemia, right? Easy to check this too, okay? Check their skin turgor, pinch their skin. If it stands up like a tent, they're dehydrated. Check their mucous membrane. If they're hypovolemic, you're already fixing that because remember we said IV IO access. When you get IV and IO access, you're already hanging 500 ml or a liter of fluid, so you're going to fix their hypovolemia. And if you think it was caused by like hemorrhage, also order some blood, right? Especially if you're in a hospital setting, go get a bag of O negative. Now, H plus stands for excess hydrogen ions. That means they're in acidotic state, okay? To fix that, we give bicarb. The dose you have to memorize is 1 milliequivalent per kilogram, okay? It's easy. There's a lot of ones here, right? Epi's 1, bicarb is 1 milliequivalent per kg. This is not weight-based, right? This is just 1, but I'm just saying it's easy because it's 1. That fixes the acidosis. Now, hyperkalemia, too much potassium, you give the same thing, bicarb. And you could see this with the peak T waves, right, on the EKG. If they're hypokalemic, then you have to give them potassium, so that's going to be potassium chloride, 20 milliequivalents, that's the dose. If they're hypothermic, right, that's, you feel their skin, they're freezing cold, that's easy to assess. You got to warm them. Warm blankets, warm room, warm normal saline. So that's the H's, okay? You have to think about all these while the CPR, while the epi is going on, okay? Now the T's. T stands for toxins with overdoses. We're going to get into that in a minute. If they took too much of a pill, intentionally or not intentionally, you could have put them into this rhythm. Tamponade, I think usually that's trauma, right? Like car crash or something like that. There's too much blood in the pericardial sac pushing on the heart, so it goes into one of these dysrhythmias. Treatment for that is pericardiocentesis, which, one has to be trained, but it's basically putting a needle into the pericardial sac and draining that blood. Tension pneumothorax, okay, this easy to assess. As whoever is doing the bag valve mask or the oxygen, ask them if they're feeling increased resistance, okay? And also get a good history, and you could listen for breath sounds if breath sounds are absent on one side, or if there's a deviated trachea, tension pneumothorax. How do you fix that? Chest tube is definitive, but in the meantime, before that, you just do a needle decompression in the second intercostal space above the third rib, because you don't want to ruin any nerves, and mid-clavicular line, put in that needle. It's going to be a big needle, and that releases the air that's pushing on the heart, leading to this dysrhythmia. Now, thrombosis is a clot, right? It could either be a PE, pulmonary embolism, or an MI, myocardial infarction, also known as a heart attack. These, we give heparin. Okay, heparin or TPA or also TNK they're giving these days to break up the clot. Now, antidotes to the overdoses of toxins, okay? This is also, you might get this from a history, or you might just have to throw these stuff at people, okay? Beta blocker, if it's a old lady or, somebody that you think may be taking beta blockers, the antidote for that is glucagon, 2 to 4 milligrams. Calcium channel blocker, you give calcium chloride, 2 grams. TCAs, that's, sometimes used for like depression, anxiety, you're going to give bicarb, same thing as this, okay? If they took too much benzodiazepam, right, like Xanax, you give flumazenol. That is the antidote. The dose is 0.2 to 1 milligrams. If they have too much magnesium going on, you want to give calcium gluconate, 2 grams. Digoxin, give Digiblind. Opioid, Narcan, 2 mg IV. Okay, they also have nasal sprays. Narcan, super important. Now, that is basically ACLS, guys.